All right, I'll make a start. Good afternoon. Welcome to Grand Rounds. Today's presentation will be on telehealth. Most of you know me. I'm Dr. Algenes from the Robina Hospital. To start this talk, I have to mention a disclaimer that most of us have special interests. All of you have special interests in some such specialty or another. In my case, I just took a special interest in telehealth. But importantly, I do not work for the telehealth unit at the Gold Coast Hospital. And because I do not work for the telehealth unit at the Gold Coast Hospital, after all the question and answer section of today, if you have any questions, you should ideally be approaching the telehealth unit of the Gold Coast Hospital rather than me, because I'm officially not employed in telehealth. How did I get involved with telehealth? Thanks to those tele-diabetes clinics. There's a diabetes clinic by telehealth every Wednesday afternoon from Robina. That's how I got involved. That's how I developed a special interest. In order to get help for these slides, these are 5 individuals who helped me out. Now, just like in every specialty, you have a conference, one in America, one in Europe, one in Australia. Same thing for telehealth. You have American Telemedicine Association. You have the Australian Conference, and this head of telehealth of the Australian Conference for the last 15 years is Professor Anthony Smith, who works at the PA Hospital. He and I met at the conference, and he gave me a lot of help for this talk. Sean Halloran also works at the PA Hospital. What's unique about Sean Halloran is that he's American. So he also goes to America for those conferences and brings back a wealth of knowledge back to PA Hospital. I also met him at the conference and got a lot of help. Who's Matthew Page? He's an ex-nurse unit manager, presently works for the state for telehealth. A lot of help. And Stephanie Ferdinand works next to Matthew Page at RBWH for the whole state telehealth. Also gave me a lot of help for this presentation. And I especially can't thank enough Jenny Beggs, who's in attendance at Robina, for setting up those telehealth clinics. Today's talk will have this structure. I'll define telehealth. I'll show a brief history of telehealth, evidence in literature about telehealth, how it is used in some gold standard hospitals, such as PA Hospital, Townsville, and Metro North, and lastly, how we can actually earn more money for our revenue. Now, this is like a big subset and a small subset. Telemedicine is a small subset, telehealth is a big subset. If you go to North America, they refer to telehealth as telemedicine over there. All of you are aware of the routine large screens which all of you have seen, through which we see outpatient clinics. It's only one but of many other ways of doing telehealth. That is, the big screen which you see is telemedicine, but even a simple email to a patient is constituted as telehealth. Hello, Robina. Would you be please able to mute the microphone, please?
That's not from Robina, it's from elsewhere.
Yeah, thanks, Harish. It might be Miami. Miami, would you be able to mute the microphone, please? I'll move along. Telehealth, the big catchphrase of telehealth is that patients don't have to travel the long distances to see specialists in hospital. But if anyone tells you that in telehealth, you can bet your bottom dollar they have not read the evidence. The evidence is actually, I'll show you 4 clinical papers later of publications. It shows that these studies are all poorly designed, and that distance is not the only thing. We need to be more worried about clinical outcomes. There's also a video on our own intranet of how this hospital is using RFDS and retrieval services and ED together using telehealth in remote regions. And would you believe this? It's not just outpatient clinics. Even inpatients. Inpatients can also be seen using telehealth. All this is perfectly legitimate. There are ABF funding just for this. We don't usually use inpatients between the 2 hospitals, GCUH and Robina, for telehealth. But here are the slides which show linear growth over the last 3 to 4 years across all the other hospitals of Queensland of inpatient usage. A good example of inpatient usage may be, for example, you have a hematology patient and you want a hematology opinion from Robina, you can use telehealth. Whereas this, all of you are very, very well familiar about outpatient usage, where we do outpatient clinics to telehealth. This also shows a linear growth, Queensland-wide, over the last 4 to 5 years. All these slides were given to me by Matthew Page from the RBWH Telehealth unit for presentation at this talk. Next, I'll move on to the history of telehealth. When the telegraph got invented in the 1830s, a Union Army doctor during the Civil War in America in the 1860s asked for bandages. That's the first officially documented use of telehealth. We are now in the centenary year of telehealth in Australia. In 1917, there's a map on the top right-hand corner. Look at the distance between Halls Creek and Perth, where a stockman fell off a horse. And a surgeon from Perth, Dr. Holland, gave advice via telegraph to a postmaster who operated on the stockman for his injuries. In GCOH, I can't sing the praises enough of the directors of neurosurgery and diabetes for going ahead of time and their pioneering decisions to start telehealth in the year 2009. Because the telehealth department in this hospital only got established in 2016. So they were actually 7 years ahead. And Rubina, we saw our first patient 2 years ago. And we were very thrilled, Jenny and me, to see that first patient. Now we are seeing close to 100 patients that we honorifically refer to this clinic as Sputnik. And we even talk to each other on the phone in a different tone. When I actually speak to patients, I speak in a different way to Jenny. But when we talk about a telehealth clinic, I refer to her as Houston, she calls me Apollo. That's our code name we use on the phone. Then we know we are talking to each other about telehealth. Now here's the meat of the talk, the money. Outpatient telehealth clinic, ABF model, pays for both ends, the clinician end and the GP's end for patients. Inpatient telehealth services, you can only be billed from the specialist end, meaning hematologist sitting in GCOH gives an opinion by telehealth, patient in Rubina, only the hematologist at GCOH can get billed. All this is legitimate. Emergency department, very rarely do ED doctors in Rubina need help from GCOH ED department. If they do, it can also use telehealth. Again, only GCOH ED gets the money. There's something called store and forward. What is store and forward? It's never been used. It's never even been popularized. I'll come to that in the next few slides. This is also another way of legitimately getting billed by Medicare for using telehealth. But as of now, we don't have billing codes for emails and phone calls. MBS telehealth items, you can use your standard code, 132 item code, which is used in clinics, 110 item code, 116 item code, all that you can use to do telehealth consultations. But telehealth, I'll come to this later, there's an incentive funding from the government, item code 112, where you get 50% extra over and above what you have done for the consultation. Who is eligible for telehealth? Here's a map of our country. All those red regions are urban regions. They are designated as RA1. There's this website called drconnect.gov.au. If you go to the next slide, if you go onto this website, you can enter your postcode or your location and enter the location of where you see your patient. Back to the previous slide, you can only see patients if you are in RA1 outside of RA1. So there are various degrees of rurality, RA2, RA3, RA4, RA5. You can only see patients in RA2, RA3, RA4, RA5, but not within RA1. Example, if a GP from Palm Beach Surgery phones up GCOH asking for a consultation, it can't happen because Palm Beach Surgery GP practice is within RA1. Whereas if someone from Roma asks, it can be done. Now we're going to move into 4 clinical evidence-based literature papers. Before I lead into this, all of you know that 70% of the Australian population live in cities, 30% live in the rural areas, and that the life expectancy is poorer and the clinical outcomes score poorer for those living in the rural areas. This may be attributed to poorer access to healthcare, and this has given rise to the phrase tyranny of distance. In keeping with the space theme, what is the distance between the Earth and the Moon, audience? Some of you can use the iPhones. Get it? Dr. Rita looking at the iPhone. 384,000 kilometers. The first paper, Anthony Smith in action again. He writes this paper about 220 daily burns, 220 burns patients, children suffering from burns, between 2001 to 2006. He used telehealth to see them because there's only one burns unit in the whole state, that's in the Royal Children's Hospital. And all these patients are from the smaller towns, Gladstone, Gympie, Mount Isa, etc. All these patients were seen, and he calculated the distance they did not have to travel to benefit from telehealth. Over the 6 years, he found out the distance of 1.4 kilometers, and he says that is the equivalent of a return journey from the Earth to Moon twice. So distance is not the only thing of telehealth. This paper is a revolutionary paper by, again, Anthony Smith. He has gone through most of the literature and all the meta-analyses of telehealth. You even have a journal in telehealth, Journal of Telecare and Telemedicine. And these journals, they're even meta-analyses in the Joanna Briggs Institute and in the Cochrane Library of telemedicine papers. So I'll give you an example. If I do research on 50 patients coming to Robina Hospital face-to-face clinics, and 4 months down the line I look at their HbA1c to see if it has improved, then I take 50 patients from Roma by telehealth, whom I saw from Robina, and then look at their HbA1c 4 months down the line. That's not a good analysis. The reason is because the environments are different. The availability of food, the exercise, the lifestyle is different geographically between Roma and Robina, between the people living there. So therefore, the research should have been done by a clinician flying by aircraft from Robina to Roma, seeing 50 patients in Roma face to face, and also another set of 50 patients by telehealth from Robina to Roma, and then if you do an analysis, that's a properly designed study. Sadly, most of the studies published in literature are like the former type. They are not well-designed studies. Sadly, there's been a lot of pressure from the technology, which is rapidly expanding, to push telehealth. And the research is technologically driven. The authors also say, what type of analysis is required before you do a study that has often never been thought of before publishing in telehealth? What type of analysis do you need? Diabetes is one example. We all know they get cardiovascular disease. There are beautiful papers published, even this year and last year, showing that there is no benefit in proactively screening for cardiovascular disease in diabetes. It makes no difference clinically. Because these researchers had the brains to ask the question before doing the research. Whereas in telehealth, it's all technologically driven. Studies are poorly designed. They're comparing apples to oranges. Therefore, I think, and also the researcher thinks, that distance benefit, they keep talking about distance saved, that's an overstatement, because clinical outcomes have never really been written properly in telemedicine publications. That's a big message to take home. Next, a third of our third article we're going to analyze are some statistics. We'll ask some friendly questions to the audience. What is the percentage of telehealth in proportion to face-to-face consultations in Australia at this point in time? Percentage figure. Anyone in the audience? Less than 1%. Very low. America, they want to make it 50%. In Australia, they want to make it also 60%. Second friendly question to the audience. Amongst our 17 health service districts, where does Gold Coast rank for usage of telehealth? Yeah, that's the right answer, but I want to show you a slide at the end. Next question. Among all the states in Australia, who is the highest user of telehealth? Absolutely correct. I've got a slide. And lastly, among all the specialities, medical, surgical, orthopedics, everything, who's the highest user of telehealth? That's for Gold Coast, but for the whole country, mental health is the correct answer. Absolutely spot on, Dr. Buckmaster. Here are the slides. Mental health, 22% highest. And the middle section, Queensland. If you can't win in NRL, you can definitely win in telehealth. Townsville, which made it to the finals of NRL again. Townsville, this is a paper. Most of you will recognize this name. Sabi Sabi-san is a consultant oncologist at Townsville. You know him very well, Jasota. So he wrote this paper where he did a simple subtraction. How much does it cost to set up the practice? For project establishment, for staff, for travel by Qantas Airlines. There's only one airline, Qantas, from Mount Isa to Townsville for oncology consultations. And then I did a difference, how much money is saved, because when you travel, you have to claim costs from the hospital. And he found out the rest, the net saving is $320,000. And he says the putting it up should need to increase by 72% to offset this gain. This is an important slide. Until July 2011, an MBS code did not actually exist for telehealth funding. In 2013, the government said, for the next 4 years, we are going to give the whole country $30.9 million to establish telehealth in rural areas. Now that 4 years is finishing next year, next financial year, 2018, June, it's about to finish in 7 months' time. That's the money is going to come. So whatever happens after June, we'll have to wait and watch. But this money was definitely given by the government. And some very smart clinicians across the state have snapped onto it, such as Metro North. I'll come to their statistics soon. So you get paid if you use all your standard codes, 132, if you're doing a long consultation, 30 minutes, 2 diseases, or 110 if you're doing your standard 1 disease consultation, 30 minutes, or item code 116. This $30 million allows you to put an additional code, item code 112, and with that you get 50% of whatever you have billed from both ends, the clinician end and the GP end if you're seeing outpatients, or at least from the clinician's end if you're seeing inpatient to inpatient consults. In the interest of time, a very small trip to America. This is what they are doing in America. Teleradiology, transplants, maternal fetal medicine. But Sean Halloran, he's American, he told me that there's a problem in America because very few countries enjoy free public health access as in this country. Most countries, it's heavily privatized. So in America, actually, ironically, the doctors own more if the patient from a remote area travels to see them rather than use telehealth. So the doctors are frowning upon using telehealth in that part of the world. At this stage, we'll take a brief interlude. And this might interest the neurologist in the room, clinical director. 30 seconds.
Meet RP7, one of Mayo Clinic's telemedicine robots.
Sir, what brings you into the emergency department today?
I was putting on the putting green and I felt my left arm got numb-like.
Any trouble expressing yourself or speaking?
No, just my arm and leg.
These technologies give doctors and patients access to experts like Dr. DeMarshall,
even though they're miles apart.
It allows the stroke neurologist to be anywhere.
And that's critical for stroke patients. You see,
In the interest of time, that's where I can have to stop about the robot. So a stroke robot definitely does exist. And PA Hospital Center for Online Health, they say they're trying to spend $10 million to get a robot that looks like this. Can you imagine a robot like this walking across MAU in Robina? How will that look? It might well be reality in 10 years' time. Moving to nephrology, I'm cognizant there are nephrologists in this room. Thanks, Dr. Balaji. This was an old slide, but at the moment, at this point in time, there are about 40 patients seen by nephrology from outreach clinics and home dialysis. But this is an old slide where it shows even other hospitals that's comparative. At the most, 40 patients at the most. In most other hospitals, 20 to 30 patients. In other words, it's not 100 and 200 patients across other hospitals. Now we'll move across telehealth in Queensland. Telehealth in Queensland. The central unit, as I mentioned, is Royal Brisbane Hospital, where Matthew Page and Stephanie Ferdinand work. It's the largest managed video conference network in Australia. There's a dedicated support member. There's 4,000 systems. You must have seen that Bravia screen, that large screen across many wards. That is the telehealth system. And 70 specialties are using it, 70 across Queensland. And it's growing by 40% each year. Every hospital should have a telehealth coordinator and a clinical lead, and we have definitely 2 such individuals in this hospital as well. The telehealth support unit in Brisbane services the whole state. And I can tell you from personal experience, sometimes I've had difficulty dialing into Roma or remote regions like Surat or St. George. I phone up this number, and they're the most helpful individuals I've ever met. They always go the extra yard to help you. Statewide telehealth unit in Royal Brisbane Hospital also manages all your video conferencing network infrastructure, so if there's a small function, they'll come and repair it. They even have a 1-800 number. Extremely helpful individuals. Also, telehealth has grown so much that Telstra have recognized it. Telstra have designed a software where they come up to you and say, if you buy this software and install it in your GP practices you serve, you can do telehealth very easily through this custom design just for telehealth. First 30 persons who come will get it for free. Health Minister Cameron Dick has also praised telehealth across several of his interviews. And those of you who have done AFA registration online recently, there's an additional question asking you, have you done telehealth? I filled the yes box with great enthusiasm. But there's one problem. I fear something. I'm concerned about something, abuse. You know what I fear? This country, it won't happen here because it's free healthcare for all. I'm talking about other parts of the world, all the other countries where you don't have free healthcare. Someone could sit in a remote country using telehealth and could see a patient in another country without registration with that national board. And can you see the slides? Yeah. And they could say, we'll see you at half price, and they could abuse the system, and that way they could actually gain money illegally. And I think you'll hear about this in the news in the next 10 years of doctors abusing telehealth for financial gain. Moving on to PA Hospital. PA Hospital has this open door, one day in a year. All of you are welcome. They open the doors. You'll meet Sean Halloran. You'll meet Professor Smith. They have done 96 publications in telehealth. They serve 32 specialities. They even do research. And especially I'm going to talk about their geriatric service, which serves Kingaroy, Dalby, Central West, Warwick, Beaudesert, and Roma. Moving over to Metro North. Metro North is the king of telehealth in the whole state. They have this cognitive assessments unit, 13-bed complex. They meet for patients with an MDT setup with psychogeriatricians, geriatricians, nurses, allied health, social workers, speech pathologists, etc. But here's the key. They follow them up after discharge. The key word from this slide to take home message is hospital avoidance. They do hospital avoidance. And I'm cognizant, and you definitely use a little iPad to use telehealth. Very good. So it's being used here as well in geriatrics. They use hospital avoidance. How many times we see in MAU, we come for the ward rounds. Nursing home not able to cope with patients' behaviors, dementia, they are in MAU. Maybe this could be used as hospital avoidance, telehealth, in conjunction with the GP. It needs talks with the PHN, it needs talks with the GP. You can avoid patients being admitted and save money for the hospital. In the interest of time, I'll move into this. Very important to remember that nursing homes and Aboriginal health services within RA1, within urban areas, are considered rural. Nursing homes and Aboriginal health services are considered rural within RA1 urban areas. Whereas obviously nursing homes in RA2 and RA3 are considered rural because they are in rural. And the government allows you to use the 112 item billing code for all nursing homes within a city. So there's no reason why we can't service all the nursing homes from Gold Coast and Robina for hospital avoidance. What are the benefits if you use telegeriatrics this way? There's continuity of care with one physician, rather than seeing half a dozen different physicians in MAU with repeated admissions. Reduces the money of travel by the ambulance to the hospital. There's opportunity for better outcomes. Specialists and PHN can work hand in hand. And there's cost reduction. And it opens new revenue streams as well. How much of money was gained by telegeriatrics for Metro North? This OOS means occasion of service. All of you know we use provider purchaser model here in Queensland. ABF is activity-based funding. This is how much of money they've earned to the medical officer, and $430 for February 2017 by doing telegeriatrics, Metro North. And because it's billed from both ends, this is how much the nursing home have earned, $528. For 3 months, their total how much money they've earned, around $1,500. And this is just a projection, what they could possibly earn the next few months. So I'm speculating that if just 10 specialties here use telehealth, for just 2 patients a week, you could get around $4,000, and if you use that in a year, you'll get around $208. Here's an interesting quote. Sometimes we send patients from Robina to be seen at GCUH at the Area 1 clinics. by subspecialties. And tragically, they're sent back in the ambulance, back to Robina, because Area 1 are unfortunately unable to bill the patients. So just think about the wastage of money, the ambulance transfer, and even the cost of the nurse escort. So I'm just wondering whether we could use telehealth instead to see patients as inpatients by consultations, by subspecialists at GCUH and the inpatient at Robina, and you can get billed from the subspecialist end at GCUH and also earn money. Now, store and forward. I promised I'll come back to this. What is store and forward? This is heavily underpopularized. This is not used at all. And all of you are actually using it subconsciously. All of you take photos on your iPhone sometimes of diabetic foot ulcers. You text the vascular circle registrar. I do it all the time in MAU. Take the photo of the ulcers, Lucy Guazzo, and then I text her the photo of the diabetic foot ulcer. This is store and forward. Even dermatology, if you're talking about a rash from MAU, and you're texting the photograph of the patient's rash, store and forward. Store and forward, there's an item code, and you can also get billed. Whereas you can't yet get billed for emails and telephone conversations, but you can get billed for store and forward. Now all regions in Queensland are taken, sadly. All the regions in Queensland are taken by PA Hospital and Metro North. Have conquered the full state. But this is what Sean Hararan told me. If you're looking for a region to really grow your telehealth, you should look at Northern New South Wales. So this health service district should be looking at Northern New South Wales as a target area. Another thing about receptionists. Remember, it takes twice as much time for a receptionist to book a telehealth appointment as does a face-to-face appointment. Because you have to call up the patient, you have to call up the GP practice, or the local hospital, be it Roma, or St. George, or Chinchilla, or Mount Isa, and also your own hospital here. You must also take into account annual leave of the doctor. And in my case, I'm also part of that, the wonderful committee, after hours committee, which also meets on Wednesdays, so that eats into the telehealth clinics. So all that has to be taken into consideration. And the receptionist often has to spend twice as much time as compared to a face-to-face clinic. Please bear this important fact in mind, because you might need more receptionists if you are going to increase your telehealth service. You might need to employ more. Coming to the end of my talk, here are what the other hospitals are doing. Metro North, online antenatal. So the pregnant lady can access antenatal clinics from the comfort of her own home without going to Metro North. Here are the other potential uses. They use it for gamma knife at the PA hospital. They use telechemotherapy in Townsville. They can even do remote swallow assessments. And Sean Halloran told me that they can even use it for otoscope. You can even put an otoscope into a ear and do it by telehealth. Palliative care, and it's definitely, we use it a lot in this health service district, palliative care, second highest. Admitted geriatric assessments can also be used. Teletrauma can be used. Telepharmacy. And there's no reason why non-Queensland health facilities can't use our facility, because Skype can easily be hacked, so we don't use Skype. We can use our Cisco Jabba program, but that's within Queensland. So what to do with someone from New South Wales? You can do telehealth with anyone in any part of the country. So for New South Wales, we can use telehealth portal, where this gets emailed to the other hospital, this portal. They click on this portal, and you can do from your health facility over here a telehealth consultation. This is why they are so helpful from Royal Brisbane Hospital if you need any help. Here I let the patients speak for themselves about telehealth. Some patients say that they can sit at home, it's the best thing since sliced bread. This kid on the bottom right-hand corner seems to like the robot. He's in Mount Isa. On the bottom left-hand corner, there were some twins born in the Royal Children's Hospital. They were seen from a remote region in North Queensland, on a remote island. They were seen in Norfolk Island by telehealth after they were delivered by cesarean. Here are some more success stories. But it's not all positive. I've spoken to certain GPs. They have often complained and said, you know what, when we do teledermatology clinics, sometimes we get a very professorial opinion by teledermatology, and then we never see that specialist again. And sometimes in the cities, they don't have practicalities of getting medications in a rural center. So some GPs are also anti-telehealth. And many practices I went to, sometimes GPs say, Thank you very much for your service, but we don't need you. We're happy we can manage it by ourselves. We just need mental health. We're doing mental health services for telehealth a lot. We don't need any more. So it's not all positive. There are also some negatives. And that's why the Australian telehealth conference held every year, Professor Smith calls it SFT, Success and Failures in Telehealth. He doesn't call it the Australasian Telehealth Conference, he calls it SFT. Because he also wants to talk about the failures. And I think that's the best way to grow, is to use your failures to push you ahead. Coming to the gold standard, which is Metro North, they have done 8,300 outpatient service appointments, whereas ours in Gold Coast, we used 491. There's a considerable difference. And 2016, 2017, 811 appointments. That's a 65% increase in activity. So that's good, but it can be better. The big slide, this slide is given to me by Matthew Page from the telehealth unit in Royal Brisbane Hospital. And here's the answer to the question I asked earlier. I let the slide speak for itself. You can mull on the numbers. Where does Gold Coast rank among all the usage in the whole state? Most of you read sports, follow sports. They say the only way is up, and the bottom ranked team. So the only way is up. Amongst Gold Coast, head and shoulders on top is endocrinology, and I'm not being biased. Endocrinology is right on top. Excellent service from Monday afternoons, from GCUH, and Wednesday afternoons, a small little telehealth clinic from Robina. Closely following us up is palliative care. Neuropsychology is third, nephrology is fourth. It is actually growing. Audiology is fifth. You can actually see the growth. Now there's even a KPI for telehealth. It should be, they say for KPI, it should be 20% increase of the previous year. But if you look at the difference of increase in endocrinology and palliative care especially, that might be what's causing Gold Coast to go higher. So we clearly can improve. And the whole point of this talk is to make awareness of telehealth and to increase our telehealth and help our finances and do good for the hospital. These are my last two slides. What are my recommendations? My humble recommendation is to increase telehealth across inpatients, not only just outpatients. Because we can't send our patients to be seen, inpatients, to be seen at Area 1 clinics from Robina. Maybe if they are seen by telehealth, they can also gain money for GCUH as well as benefit what's most important here, which is the patient. Now all specialities have this rapid access clinic, all subspecialties. This is where telehealth can be used. So I put the question to Professor Smith. I asked him, what do I tell this audience? They're going to be clinical directors here. They're going to be very senior clinicians. What do I tell this audience? How to grow telehealth? And he told me to tell this audience, start slow and go slow. Start with one clinic a month. Start with one clinic a month. And it takes about 3 to 6 months for it to increase. After that, after 3 to 6 months, you can go to 2 clinics a month. Start slow and go slow. So I've delivered Professor Smith's audience, delivered his message to this audience. You will earn a lot of money from telehealth as Metro North have earned. And then you can fund the receptionists, you can build the center even more. For the PA hospital, it's a large center with 12 separate work desks, which are all soundproof, with half a dozen receptionists. We can clearly reach that level. I think telehealth is the way of the future. Publications in telehealth, sadly, are not well designed. The clinical outcomes are not well looked into. That's a big take-home message. So all those who tell you that, oh, telehealth is going to save us the distance of travel, they haven't read the papers, you can tell. If they read the papers, you can see clinical outcomes are not yet well researched. There's enormous benefits to patients across Robina and GCUH in northern New South Wales. All of you know how crowded the M1 roadway is. All of you drive home from Robina at 4 o'clock. You know how it is. I have a feeling all these patients in northern New South Wales who travel here, who don't need a face-to-face consultation necessarily, can be seen by telehealth. I would have also thought that cost savings for DEMS appear very promising, and definitely some money can be saved in this way. And so what we need is a united trial of the will of the executives, will of clinical directors, and telehealth unit, which is more robust and enthusiastic. All three working in unison will form a strong alliance to increase our finances and increase the health of our patients and help us grow. Thank you very much for your kind attention. But coming back to the very first slide, all questions you have after today should be directed to official channels, which is not me, which is the telehealth unit of the hospital. Thank you very much. Yes, Mandy. Are you? Wonderful. Pleased to meet you then. Good. Any questions from the Rubina? Any questions for Rubina?
No, we're good. Thank you.
All right. And Miami, any questions? Yeah? Yes, sir. Beautiful question to ask. Absolutely superb. And I worked in Townsville Hospital. I worked with Lyndon Robert. Yes, tell the question again, yes. So Rubina and Miami, the question was from Dr. Jayapro Ijo, that he does rheumatology clinics, and he feels sometimes he cannot entirely rely upon the GP's judgment when they examine the joints. The synovitis is such an important thing in rheumatology. So in that way, how do we get around the problem? You're right. In that case, you don't have a choice but to see them face to face. And that depends between rheumatologist and rheumatologist. Because in Townsville Hospital, when I worked alongside Lyndon Roberts, rheumatologist, Muriel Soden, rheumatologist, they were doing telehealth clinics, and the GP was sitting at the other end at Mount Isa. And I've seen it in action. The GP process with synovitis. You're quite right. If synovitis is the question which is so specific, which is everything to do with rheumatoid arthritis, for that, you have to rely on a face-to-face appointment. Absolutely true. But there are those rare patients like biologics. In PA Hospital, they use biologics who are well treated on biologics for several months, are doing very well. Such an appointment where clinical examination is not necessarily needed can definitely be seen through telehealth, if you are comfortable with it.
Dr. Algenes, is the Gold Coast Sexual Health Clinic here. Do you mind if we ask a question?
Yes, you can.
As HIV medicine has joined the realms of chronic disease, we're thinking of using telehealth for some of our consultations. And based on the some points you made about the lack of evaluation on clinical outcomes, do you have any suggestions about what clinical outcomes we should be looking at?
Very, very beautiful question. Yes, you're quoting what's written in the papers. That second paper I showed you from Anthony Smith, he says all authors end their manuscripts in telehealth publications saying, quote unquote, well-designed and larger studies are required. Well-designed and larger studies are required. That means the studies are not well designed. So how to design a better study? So a lot of thought should be put into telehealth. It's not just the cost benefit because of travel. You must also look into clinical outcomes of the patient. You must compare apples to apples, not apples to oranges.
So, for example, in your realm,
that's where the mistakes has been made in all the publications.
Yeah. So, in your realm of kind of, I suppose, endocrinology, what sort of outcomes are you looking at?
We only do one thing, don't we, Dr. Ravan? Just HbA1c. We can't look at diabetic foot through the screen. We just do HbA1c at the most. Yeah, that's right. They're all quite high.
And I think it's important that, particularly in chronic disease, patient education, understanding outcomes, and compliance with recommendation.
That's quite helpful. You can't measure that.
All the patients are not from RA1 outside.
Yeah. Roma, Chinchilla, St. George in the southwest area, and Mount Isa and one or two from Mackay. And they're also doing virtual ward rounds in Roma using clinicians from PA Hospital. Using that same screen, they just push the screen bed to bed at Roma. Even that's possible through telehealth. But all these areas are now taken over. Even our area in Roma is now taken over by PA Hospital. We're getting less and less referrals, but it's enough to keep us busy. And that's why I mentioned the target area as mentioned by Sean Halloran for us should be northern New South Wales. That's not yet used by all the other hospitals. That's custom made for us to serve.
So there's two things. One is to telehealth or telemedicine. The most important thing is to reduce patient travel and improve patient outcome. The second thing is the money part of it. So to build, you have two healthcare professionals on both ends, right?
That's true.
Really. So in oncology, sometimes we see patients, we can link with the patient at home without the healthcare professional, but we can't do that stage.
That's one thing, yes. You can link them, but at least you will get billed. At least your end will get billed, if not the patient.
My understanding is if you don't have healthcare professionals on both ends, none of the things can get billed.
You can. I do it. There are one or two of these patients who have diabetes. These are single mothers who don't have time to go to the hospital, and they're also working in Roma. And these guys, I see them from their home, and it's totally legitimate. And she might offer more. It definitely can be done.
The difference is you can find any telehealth consultation. The difference is that you can find both ends, as a provider and a receiver. You can always find.
Yes. Fantastic. Any other questions?
A comment rather than
Yes, Faid.
in chronic disease management, telehealth is a good way to upskill people. In many of our cases, it is set in with the patient, and the discussion we have with the patient, we also have the chance to reinforce certain management practices or management practices. And whatever foreseeable plans you have with the facility, for this also, passing away of GP.
That's true. Any other questions from Robina? Miami? Okay, we'll call it a day. Thank you very much for your kind attention. Thank you. Yes, Maria.
Thanks for recognizing me. But I'm doing like lots of visits like iPad consultations, and one thing I can't do is hear their heart and lungs. Is there anything coming soon with a virtual stethoscope which you could attach to your iPad?
No, that's not there. No, that's absolutely not there. No, not even in America.
But you know how the cardiologists now have the ones that amplify it and what have you? Are you sure there's no like Wi-Fi that will connect to an iPad? If you see anything, will you keep me in mind?
Sean Halloran is the man to ask. Yes, I meet him quite often.
Could you ask him because?
You'll ask him.
Because I would think I should be able to put a stethoscope or even have a Wi-Fi. So the team that goes out to to see the patients, we could just put the stethoscope onto the scopes, and then I would be able to.
If they can do otoscopes, why can't they do stethoscopes? You're right. I'll ask Sean Halloran that. If they can do gamma knife, why can't they do this?
And especially now that so oftentimes the stethoscopes are augmented, like they amplify the sounds. I'm wondering if they couldn't send it by Wi-Fi to the so if you hear of anything like that.
Definitely, yes. They hold a conference this month.
Yeah.
Somewhere on the 30th. Two Mondays from now. In Brisbane. TELEHEALTH conference. I'll be meeting all of them again.
Oh, great. Well, ask them for that. My problem is that I'm doing this GenMed, which is during sitting at home. Supposedly I can't bill for my time. So we're doing a lot of telehealth, but it's not being captured because it's not.
Exactly. This is where this telehealth coordinator, this is what's the problem here. The problem here is they're just not going out to all the specialities and telling that we exist. They're just sitting in their office and not. That's a problem here. You see how bottom ranked it is.
And also, anyway, I don't want to get into the money, but they can sort out the money if they want to do. But I do know that I'm doing pretty good with seeing the patient, talking to them, just with the stethoscope on chest. Because my team can do the blood pressure, do the pulse ox, do all that. But I still don't have somebody who I can say where their preps and how it's like a heart scan. I'm pretty sure there's some
We'll definitely ask him.
virtual stethoscopes.
We'll definitely ask Sean Halloran.
All right.
He's from your part of the world, your neck of the woods. You'll know it.
I'm sure there's some smart geek out there. Thanks.
Anytime, man. I'll save it for you. Oh, dear.
What's going to do that? Starts looking at the